Is the slide visible, please?
Yes.
Yes. Thank you so much. And thank you. It's an absolute honor to be here on this platform. I follow this very diligently over the years, and it's a lot of learning. I've been listening to all the speakers, and my previous speaker was very interesting. I wish we had, as Sir said, 100 years of glucagon. I wish we had it, and that would mean I would not have to make the presentation that I'm going to make now. So my topic is learnings from managing physically active children with type 1 diabetes. What I did was, because I felt that it's when I talked to lots of people, I realized many people in the space of taking care of children with type 1 diabetes are not really following any kind of a structured practice when it comes to exercise. We do have lots of structured nutrition. We have lots of protocols, we have carb counting, we have guidelines, we have so many things, but we do not have a specific protocol in each clinic where we follow physical activity. So I thought I'll go guideline wise while taking the leaves out of the guideline, yet emphasize on each topic in a practical way, what we can do in our clinics. So as far as the guidelines, and these are the ISPAD guidelines, and I'm going to be very specific and translate into what it means in day-to-day practice, is that, okay, first of all, there has to be an individualized management plan. Now, that plan has to include what kind of type and amount of carbohydrate would be needed for their activity. For that matter, first it has to include what is their activity going to be? What is the best time for that activity to happen? And then, as we discussed earlier, which is again, it's like being post-reactive or pre-active, but in both cases, carbohydrate adjustment and insulin adjustment, because these are the only two things we have till date. And my point is that, do we do this in our clinics? So even in Udan, where we have children who are working in the fields, they are running after the cattle, they are picking crops after they come from school. Their school itself, they'll be cycling to school, and that would be a few kilometers of cycling every day. So it doesn't always have to be exercise. It also often is a day-to-day activity level, which can be very different for an urban child versus a rural child. And again, in school, there are schools that would have games every day. There are schools which would have just once in a week, and some schools which would never have games. So my point here being, as per the guidelines, but also practically when a child comes, the way we take a recall for nutrition, we have to have an activity and exercise recall. Of course, if the person living with type 1 diabetes is sedentary, then as Dr. Sri Ganesh mentioned, that they actually need to exercise even more than people living with type 2 diabetes. And that is a different aspect that we will motivate them. But for those who do, in my case, when I see children, and especially I'm working with rural children, all of them are very active, including girls. If nothing else, they'll be dancing, they'll be going to get water from the well, they'll be running onto the mountains, and it's a lot of activity that happens. So first and most important is to document it, to understand, and then talk to them about how do you adjust carbohydrate with that activity, how do you adjust insulin with that activity and exercise, and of course, what is the best time, because it cannot be like grazing in food, like similarly grazing in activity. Now, also a plan which has to be taken with the school. A lot of talk across the country is happening about school care now with the CBSE board and the government GRE, which has come, where you can take your pump, you can take your CGMS, your glucometer, and even your phone, a snack into an examination. Similarly, it should encourage all of us to give letters to the school, whether it is a remote rural school or or it is a public school which has a structure, a nurse. But each one of them, in Udan, we send a letter and we do plan. We ask them for the week's timetable. We see whether the child is going to school walking, or what time is the break, when are their activities, what are their study hours. And all that is planned initially. And if there is any change, the teacher is asked us to inform. Usually in 3 months, there is some change in the cycle, and we have to plan this once in 3 months with the patient and patient's family and also the school. So initially, it should be, what is the initial exercise care that we want, the management? Care should be taken from very basics. Are there blood glucose meter and strips chosen which are suitable for where they are? Because that care starts from there. We have so many children nowadays who are going for evening classes. They're going for skating or yoga or something. But are they carrying their glucometer and the test strips for them? And if they can, then we can, those who do not know yet, but they want to train their children, they have asked them to go for a tennis class. Sometimes it's not even just for exercise because it's a trend, it's a fashion, it is cool to be doing this stuff. Sometimes they're doing the right thing for the wrong reasons, but they are doing it. Then it's very important we also let them know that there is technology available like CGMS and a pump, which might make it easier for them to go into a structured exercise program. So ensuring they have a monitoring system is first part before taking care of physical activity. And this is something we do in the remotest of our children. I mean, no matter where they are. I have children whose families they are nomads. So they would walk 20 kilometers a day because they don't stay in one place. They keep walking. They have these cattle which they take with them. And yet so accordingly, everything has to be managed, and that monitoring becomes a key factor. So we ensure that they have adequate strip supplies wherever they are. Again, keeping a record of their physical activity, food, and glucose levels. For example, I mean, I can imagine with all the technology that we were talking about, it makes sense that, we have a record and all. But what about a child in a village or even in a town? Most people are still on multiple insulin injections and would have a glucometer. So SMBG with multiple doses of insulin, they have to log. And I know they do not like to log. So at least initially, till we understand them, the easiest part is today you can log on the phone. And if children don't like to write, but at least for us to plan, we need a very high quality data, because otherwise, how will you plan the doses? How will you plan how much carbohydrates? How will you plan what kind of correction doses? Who will receive? And that cannot happen without this data. So first 3 months, we insist, and we sometimes, beg, borrow, steal, whatever way it is to convince them that a log is very important. And then we see those patterns, and that gives us the data from which we can extract that this is the pattern which is suitable for that particular child. Now, although the prevalence of diabetes complications is low, but still it makes sense as a protocol. It is a good guideline to give a letter to all the children, for their coaches, for wherever they're going, telling them, giving them permission to participate or whatever care is needed. So if a child is going to a tennis class or is training for a marathon, it's very important that we give a letter officially from our end, although we do see very few complications. Again, patients who have proliferative retinopathy or nephropathy should definitely avoid resistance training-based exercises or anaerobic exercises, which could raise their arterial blood pressure. So that is something they are told initially itself. Now, once we have set the stage, so my point was that as per the guidelines, we can translate it into the highest resource to the minimal resource, but we cannot skip it. So we do sit with a child and create a conversation, create a plan, log for 3 months, get high quality data, and then guide specifically on how we can manage their exercise or even activity levels when it comes to rural areas. So what are the general situations at the guidelines? This is just for our knowledge, because often I find that even these are things not told to the students or the children, and then things go haywire, as we know. So elevated ketones is one thing we should all know about. And it's important to identify the cause, and it is definitely a safety concern. Ideally, exercise should be postponed until and unless until it is cleared. Still, high intensity exercise is definitely dangerous. When it is above 250, it is important they check their ketones. Now, I just want to say, often I get people say, how is that possible? I just want to tell you that I have right now maybe 1,300 kids in the villages. Each of them have a keto strip. I know we don't do the blood ketones in rural areas, but I'm just saying they at least do their ketonuria. They check it. And every time the sugar goes above 250, they check their ketones. And if it is high, they talk to us. So I feel if we take it seriously, it is definitely possible. And I'm sure this has prevented many complications, acute complications that would have happened. So focusing on ketone and avoiding exercise, waiting, finding the cause, seeing hyperglycemia, and not exercising when the sugars are high at that moment is also as important as we are focused on hypoglycemia. Hypoglycemia is something even children are focused about. Their families are focused about. Hyperglycemia is something, there's a misconception in the general public that, okay, my sugars are high, my child will run and the sugars will come down, or my child will exercise and sugars will come down. So it's good to exercise. I have heard people say, okay, your sugar is 400, why don't you start exercising? Your sugar will come down in a person with type 1 diabetes. So these are the things we need to make people understand. And unless and until we tell them, they think it's just common sense, which sounds logical, but is not okay. Now, severe a very nice discussion has already happened on hypoglycemia, but it's important that we put it into categories, into buckets. In a practical scenario, that severe hypoglycemia on the previous 24 hours is a contraindication to physical activity. So it's not just now. That is something I have to tell all my children all the time, because for them, suppose, like, for example, we had a trek last week, and one of the child in a village who was supposed to participate in the trek had a severe hypoglycemia for a very not okay reason, in the sense did not get food and all that, but insisted on coming for the trek. So we said no, and was very upset, and we had to explain why. But it's very important to understand that severe hypoglycemia is a contraindication. Non-severe hypoglycemia, which has occurred recently, can also, as we were talking about the counter regulation in the previous talk, and that can lead to deterioration of the hormonal counter regulation during physical activity, ultimately increased risk of recurrent hypoglycemia. So one hypoglycemia begets another, and hence again, we have to be cautious. Maybe we can't always deny a child from activity, but we have to be very cautious. So all situations of documented hypoglycemia prior to a physical activity, we have to be very vigilant in monitoring. So what we can do if we have to allow activity is very frequent monitoring. Like in Udan, we do these 25-kilometer treks. We do quite extensive physical activities together as a group. And that is what we do. We monitor very frequently. And that is a time they get trained during the camps to manage, because then they know that they can have a late hypoglycemia, how to pre, intra, and post exercise manage. So this is a hands-on learning that they get about all the three things. Now, children have to be encouraged to measure their blood sugars before, during, and after exercise. Now, let me tell you, I know what people living in this space are thinking, because my kids too, they do it when they are with me in the camp, and they do it for a week after they go away from the camp, and then it starts dwindling, because then they assume we know our body, we understand, they understand their symptoms. So it's really not easy to convince them to do it all the time. But it's very important we keep saying, and somewhere it makes sense, and then they are able to. Other aspect is, of course, to check sensor-based glucose values is on a regular basis is very important. And if we have predictive alarms and low glucose alarms, all the technology can really help. Now, just having a CGMS does not help. I raised funds in between to give CGMS to all the children, and they would not just scan it. I mean, just not looking at it also. So it's not just enough to have it, it's very important to actually look at it. And of course, when you look at it, to interpret it. So these are very little things which do not translate from a guideline, which you think logically would happen. Hence, we have to ensure it. Again, high glycemic index snacks should be readily available. I know, as we discussed in the last talk, it's not the best solution. You end up having too much. It's lots of overnutrition in a way, but they have to be available. They, as a rule, they have to be available. There's a whole list available. Whatever is locally available, I always like not to give something very delicious or candy-like, because then it doesn't stay till it is really needed. Children end up eating it whenever they want, and that is only natural. So they get tempted. So it would be very important to define this and give it to them. In Udan, we insist on an ID card. Every child in the remotest of areas has to have an ID which talks about their diabetes, and this is absolutely essential. So a high glycemic index should drink or a pouch, whatever, and a card are two things that every person living with type 1 diabetes must have. We had a case where a child was traveling in a train and went into hypoglycemia. The mother could not get sugar from anyone. She was not carrying her glucose, and I think they bought it from some tea vendor, and they paid like some 500 rupees for 2 spoons of sugar. I mean, that's a really depraved humanity at times, but that kind of, at least they got it, and that was important. But these are all anecdotal things, but point is that we have to be very firm. We have to really, really insist, and this is very important. And communication from otherwise also, who are they going to call? Who is the coach going to call? Who is the teacher going to call? How are the children going to call? If the phone is not there, how are they going to reach out? So this has to be worked out. It's as important as insulin. It is as important as learning how to adjust the carb intake, and communication, ID, preparedness for hypoglycemia is extremely important. And this we had just talked about, so I'm not going to repeat what was there in the last talk, but activities lasting than 30 minutes are likely to require a reduction in the insulin delivery. So as spoken earlier, when exercise is planned at the peak insulin action, that is when the rapid action is administered and after the meal, then specific reduction accordingly can be made. So it's very important to time it. I think all of us as clinicians who are prescribing an exercise know the action profile of the insulin. We know what kind of activity is happening, what meal is happening. We just have to put it all together. But that effort has to be made. It has to be planned. And now, for that, we have to have a planned way of exercise. We also know that children often do not follow a system. But it's in Udan, we have designated specific times of play times and duration. And we have asked parents to watch that, okay, if they play for an hour every day and today they want to play for 2 hours. So that's where they tick in their mind, okay, this is more than an hour now, and this is the intervention that I'm going to do. So just training them for the red flags, that what are they supposed to look for and where are they supposed to take an intervention. And if they don't know what to do, they can always call a helpline and ask if that is important. So again, I'm not going to go into great detail. Point is that we would have to adjust prior, during, and after. So these are all 3 levels which are important. So adjusting prior and during the exercise, when we are using a long basin, or we are, it's very important that we reduce much earlier, right? If it is a planned activity and suppose you're using a basin like degludec, you would like to really do it a day before. Otherwise, you would not be able to reduce the doses. And so those are, again, things which need to be kept in mind. And what kind of adjustment will be done. For example, when the rise in blood glucose level after intensive exercise, we can give there's a rise, and then that time a small additional dose of rapid acting insulin, which could be 50% of the usual correction bolus, which would be given. Or again, it could be a different activity which would bring down the blood sugar. But again, who knows this? How many people know about it? That which kind of exercise is going to bring up the blood sugar? Which kind of exercise is going to bring down the blood sugar levels? Now, these are things that we may all know theoretically, but do we chart it out for our patients? Do we tell them that this is how you maintain a balance? So it's time we create something very practical and share it with our patients and their families in a very local, activity-friendly way, so as not to also make it overbearing. I think so many instructions about exercise would make a person say that anyway, people don't want to exercise. And they would say, I don't want to do this anymore. Now, there are doses which need to be adjusted after or late evening after exercise as well. This is very important because nocturnal hypoglycemia risk really increases. As I was sharing, when we go for treks, we have to really give them a night snack. We bring down the night blood sugars. We lower the basal rate because nocturnal hypoglycemia is what we're expecting, or fasting will be low is what we are expecting. So more monitoring and more reduction, anticipating a reduction in the blood sugar levels in 24 hours after as well, and accordingly managing the doses post-exercise is also something we have to prepare our teams with. Now, what about the afternoon or late evening after exercise? For example, if they are on a temporary basal reduction of approximately, we want to reduce it at bedtime. If you reduce it for 6 hours, it helps reducing the risk of nocturnal hypoglycemia. 20% basal dose will help them. Again, a carbohydrate snack. I insist on a carbohydrate snack at bedtime because no matter what you do, sometimes I have seen like hundreds of cases and the number at night does not always predict that there will be no hypoglycemia at night. So there's a whole lot of physiology to it. But as a dictum, I insist on a carbohydrate snack in the night if there has been an exercise before. Now, we were talking about how do you manage with the carbohydrates. So intake prior to and during the exercise. So it may not be required in a moderate intensive exercise if the blood sugars are okay and the exercise is like 30 minutes. We do not really need to add. And once we have seen the blood sugars pre, intra, post exercise or with a CGM, then we know that the child does not need it. So there need not be anxiety, and all the time mothers are giving their children more snacks. Eat because you're going to play. Eat because you're going to play. So these are things we have to set at rest. But for low to moderate intensity aerobic exercise of more than 30 minutes, then we have to think of adjusting the doses. Sometimes you have to increase when that exercise is going to give them hyperglycemia or decrease accordingly. So adjusting the carbohydrate intake, adjusting the doses pre is important. Sometimes we have to give them in between also, as I said, with marathons and treks. Now, post exercise as well. So appropriate carbohydrate and protein should be with protein. This is not pure carb, should be consumed within 1 to 2 hours of exercise, because that's the time there is a increased insulin sensitivity, and that is the right time to have a protein and carbohydrates snack, and it will bring down the post-exercise hypoglycemia risk. Never forget the dehydration part, because that is a risk, and water or sugar-free fluids are also important, and that becomes part of the management in children who are exercising specifically, even who are playing competitive sports or are doing camp days or sports days in school. So hypoglycemia is, of course, the burning topic. That is something we all bear